Okay, welcome everybody to the Asthma Quality Improvement Program, building knowledge, confidence, and change in primary care providers. This is the first action period call of Wave 1. We are very happy to have you, and thank you for joining today. Thank you also to our program partners, the Ohio Department of Health Asthma Program. And I need to make a note that this is a mock-up version of their new logo with their existing asthma program logo. We are told that they have rebranded but haven't published the new logo yet, so that may change, so stay tuned there. Okay, I want to welcome everybody. We're going to attempt to launch a poll question for you to answer. Zainab, if she is on, we'll give you some data collection tips. We'll hear from Dr. Hardy with childhood asthma case discussions and also from the asthma team. And hopefully from all of you, you'll have some good questions and some additions. If we have time, I have some information in the QI corner and then next steps for the program. Okay, so in the chat, if you could share your name, your practice name, and if you are starting to see an increase in respiratory illnesses and or asthma in your practice. It is maybe another season of early respiratory illness. So we may start seeing that trickle in earlier than suspected. Okay, more tech for us. So for the poll question, do you currently use an asthma action plan in your practice with your patients with asthma? Hopefully you are now seeing the poll. So your options are all of the time, most of the time, sometimes, rarely, never, or unsure. And we'll give it a minute or so. Okay, another 5 seconds on the poll. All providers are welcome to answer this as well. Okay. Hopefully you can see these results are being shared. Most of you are using an asthma action plan all of the time, which we are grateful to see. Some of you are using it most of the time, and there is a little bit of sometimes. So I think overall we are in a good starting place for this program. So it allows us to see kind of where we are and where we need to be. Okay. Zainab, we can just move her section around. Dr. Hardy, I will pass it to you. I have your slides.
Okay. We'll go ahead and pull up that first slide there. Okay, good. So I'm William Hardy. I'm one of the pediatric pulmonologists here at Cincinnati. And I have a confession to make. This is the first time I've ever done a quality improvement type of a project. But one of the reasons why I'm doing this is I feel like I benefit so much when for instance, giving talks like this. It really forces me to get to know the literature a little bit better and to understand some of the concepts. And hopefully what I learn, I can share with all of you. So the way this, I have about 25-30 minutes of slides. And part of it's a review of what Angela talked about a few weeks ago. And then part of it's case discussions where we can hopefully utilize some of the concepts that are being introduced now in terms of asthma management. But I want this to be open. You know, there's 3 cases. There's no right or wrong answer. In fact, I think that you may likely see that there may be slightly different ways that people manage this. And I think that's fine. The big point is that we think about the concepts and we think about how some of the new guidelines could be implemented in specific cases. So I'll throw a case up And Angela and Ava have already been recruited to discuss it, but we want you guys to feel free to chime in as well or ask questions about it. Angela and Ava haven't seen the cases either. So again, I think that's good because it will maybe, we can see that there might be some slightly different styles or maybe not. So first we'll start off with just again, a very background of what Angela talked about with sort of my spin to it. And so the primary goals of asthma management are symptom control, and you go ahead and advance, Brooke, which basically is reduce the symptom burden to the patient, and then risk reduction, which is really three components. You want to prevent or at least attenuate exacerbations. You want to reduce potential airway damage and loss of lung function, which most people believe happens because of chronic inflammation. And then you want to think about medication side effects, and that includes underdosing as well as overdosing. So trying to find that median. So I'm going to advance, Brooke. So to do that, there's really two main ways that we're going to talk about, primarily using history, and that is to classify asthma control and severity, and then identify risk factors. And by using this sort of method, I think that helps you to identify whether or not you need to potentially step up, stay the same, or even step down with your therapy. Okay. So first thing we want to talk about is asthma control, is defining or classifying asthma control and severity. And so the first thing at least I think about is it intermittent or is it persistent? And you might find different definitions depending on what you look at and what's intermittent or persistent. But what I've got here seems to be sort of the prevailing definition. So daytime symptoms that occur more than 2 days a week on average, and this usually most people go back for the last 4 weeks when they make their definitions. So daytime symptoms more than 2 days a week on average. A rescue inhaler more than 2 days per week on average. Night symptoms more than 2 nights per month on average. And then finally, 2 or more exacerbations in a year. An exacerbation meaning usually it's a steroid course, going to the emergency room, or significantly stepping up your regular treatment. So that's your definition of persistent. So intermittent would be what is not persistent. So then the next step is to rate the severity if it is persistent. So there's 3 main categories that people use: severe, and you can find a lot of definitions for what's severe, but certainly symptoms that are going on almost daily and often at night. If a patient is needing a high-dose ICS/LABA to keep from being uncontrolled, or certainly if the symptoms remain uncontrolled despite optimization of whether it's an ICS/LABA or anything they're on right now, that would be classified as severe. Moderate is going to be, you can go ahead and advance, Brooke, would be daily symptoms, but not necessarily every night or most of the day, most days. And then finally, mild will be symptoms that are more than 2 times a week, but not daily. Nighttime awakenings 3 to 4 times a month. Symptoms that are controlled, but are needing an ICS/LABA or a low-dose ICS to keep them controlled. And I wouldn't get too hung up on this, whether it's mild, moderate, or severe. But I think it's good to have at least some kind of severity rating that you have that you're going to use consistently from day to day, week to week, and year to year. One thing that we should point out, go ahead and advance, Brooke, is when you talk about mild, at least in the GINA guidelines, they want to make it pretty clear that they don't like the use of mild asthma because there's some concern that if patients hear that they have mild asthma, they're less inclined to maybe take it as seriously, maybe less inclined to be as compliant with using their daily controller medications. So I try to avoid the use of mild asthma. And generally, I just say it's either controlled or, first of all, it's persistent or it's intermittent. And then I'll call it severe or moderate, but I usually avoid using the word mild. Okay. And then the next thing is you got to rate the symptom control. And there's lots of things that can be used out there. There's a asthma control test. There's I like the GINA. I'm a little more biased toward the whole GINA guidelines. And they have a very simple thing here, which is basically 4 questions that you answer yes or no. And then you're either well controlled, partially controlled, or uncontrolled, depending on your response to these questions. Again, I like this because it's relatively simple. And another thing to point out here, we do use reliever therapy quite a bit, as in our classification of a persistent or intermittent. And they make the point in GINA that you don't want to necessarily, if the patient is using albuterol, say before exercise, don't necessarily count that as using their reliever more than twice a week, because a lot of patients just do it anyway. Like they have exercise-induced asthma, or they think they have exercise-induced asthma, and they've been conditioned to always take their albuterol before they exercise or they have activity. So you don't want to count that when you're trying to score a patient as having frequent reliever use. And that's a problem. We used to use the ACT test quite a bit, and that would make the scores much, much worse all the time, because that would get scored as being frequent need for albuterol. But find a symptom control that you're comfortable with, that's simple for you, and that you can be consistent with, and then use that when you're trying to decide is a patient controlled or not controlled, or partially controlled. Okay. The next step, after you've sort of classified the patient as intermittent, persistent, the severity, what their symptom control is to then identify the risk factors. And this could be a talk in itself, but we'll just going to focus on some of the top ones here. So go ahead and advance it, Brooke. So medication. So a risk factor would be using a short-acting bronchodilator frequently, like albuterol. So more than 3 dose canisters, that should actually say not a year, but a month. More than 1 a month is definitely a high risk factors for bad outcomes. And of course, there's always the issue of compliance and adherence to the medications. Comorbidities, obesity, rhinosinusitis can be potentially a risk factor. Certainly allergies are. Anxiety, depression are big comorbid factors for many of our patients. Exposures, so don't forget to talk about smoking or vaping, or ask about that. Try to get a good allergen exposure, and ask about vaccinations. I would consider that sort of an exposure. If you're going to be getting influenza, for instance, as Ava talked about, that's going to be a risk factor for worse outcomes for your asthma patients. Lung function, if you can do that. It's much easier for us in an academic center to get these spirometries than it might be in a community. That can be valuable if you see an elevated exhaled nitric oxide. If you see a huge bronchodilator response, that's usually a high risk factor for a lower outcome, for having more exacerbations. A lower FEV1 is also a higher risk factor for exacerbations. Okay. And then past severe asthma exacerbations, that might be one of the highest risk factors that a patient is going to have high risk for exacerbations if they've had a pretty strong history of having frequent needs for steroids or frequent emergency room visits. Okay, so kind of putting it all together, you can go ahead and advance, Brooke. You want to classify your asthma severity and control. Next, you want to identify risk factors, and then from that, finally, you're going to use that information to sort of inform your pharmacologic and your non-pharmacologic approaches to management. So that's kind of a brief summary of what Angela talked about. And I always think learning is repetition. So it never hurts to hear this again and maybe hear a slightly different angle. And once again, me writing these slides really helped me to really kind of think about this as well. So I think I benefit as much, if not more, than you all, when we do these type of exercises. Okay. So
Artie, sorry, not to interrupt. Do we want to pause for any initial questions?
Yeah, that's a good idea. Any comments or any questions?
No? Okay.
Yes,
All right.
I'm sorry. I have a question. My name is Fariba Rezai from Cleveland Clinic. Do you hear me?
Yes.
So in general, so that's a silly question, actually. The viral induced asthma, that how do you classify the viral induced asthma? Do you go based on that how many times per year they've had exacerbation? Like if the viral induced is more than 3 exacerbation, you say they are persistent, or less than
Yeah.
that, you say intermittent. What's the best way for that?
Yeah, I think that's always a dilemma. I can actually have a case so we can we'll actually talk about that a little bit more. I tell you what, let me hold on to that because that's actually my third case. And I know exactly what you mean, because yeah, you have these kids that will be just fine and then they'll get a cold and then they have an exacerbation and then they're just fine and they have a cold. So so I don't mean to not respond to that, but it's going to come up here in the third case, and I'd love to, and also like to hear Angela and Ava's thoughts about that as well. But I agree that's a little less straightforward.
Okay, thank you.
All right, Brooke, I think we go ahead. So here's our first case. We have an 8-year-old with a history of asthma, and Brooke, you can just slowly. I think there's 4 subsections here. We'll start off with the first one. So hospitalized a year ago. Prior to being hospitalized was just with albuterol. So then at discharge, you got Flovent, 44, 2 puffs twice a day. By the way, I think many of you already know Flovent is not going to be Flovent anymore. It's going to be fluticasone starting 2024. So you'll have to prescribe generic moving forward. Okay. And did reasonably well, I guess did okay in the summer. Didn't hear too much about them, but then they got admitted in September for asthma. And had to get got stepped up by adding Singulair 5 milligrams. And then 4 weeks ago, had an exacerbation in the emergency room, got some prednisone. And now you're seeing them and using albuterol, I don't know, every other day, waking up maybe once a week for cough, occasional wheeze, needing some albuterol at that time as well. So this is your clinic patient. So go ahead, advance, Brooke. So how would you classify the asthma? You can go ahead, advance, Brooke. Would you call it intermittent or persistent? And I might have to call on my colleagues. All right.
Definitely persistent. I mean, if you're having symptoms almost every day.
Right. I would agree. Ava, you agree as well? Okay.
Yeah.
Excellent. All right. So we're going to call it persistent. Okay. Next slide. If persistent, is it well controlled, partially controlled, or uncontrolled? And again, this is using the GINA guidelines, but what do you all think? And again, there's a reminder, there's no right or wrong answer here.
Yeah, it's not controlled. Yeah.
Yeah, I'd agree. Angela,
Partially controlled.
So either uncontrolled or partially controlled, but definitely not well controlled, I think we would say. Okay. All right. And then if you're not well controlled, what would you call it? Mild, moderate, or severe? And this would be the kind of thing, Brooke, I think if we did a poll, I bet you we wouldn't get the exact same answer for this. And that's intentional, because I think it's good for people to realize it's okay. As long as, I think we'll come to the same conclusion about the treatment, but we don't necessarily have to have the exact same definition as to partially controlled or uncontrolled or mild, moderate, or severe. So I don't care if people answer this question, but
I would say I hedge on this too. So I do a lot of this like moderate to severe, and the reason being, and if other people maybe have similar thoughts, they clearly are severe in their risk category. So they have had 2 hospitalizations and an emergency room visit. So I tend to say, I think it's a loaded, because you have to think about, like you mentioned, are they taking the medications too? So could they be, so I always hedge a little. I say moderate to severe.
Yeah. Good. Okay. Now, hold there for a sec. Brooke. So the next step, using this sort of approach that we talked about earlier, we've classified the asthma. Now our next step is we want to review and potentially treat any modifiable risk factors. And I could ask you guys, we already went through what are some of the risk factors, but I've got a few that we should, at least a couple that I always like to bring up. And I'll show those, and then I'll open it up to see any other risk factors that people like to always think about. So go ahead, advance, Brooke. They want to show you a picture of their pets at home. So go ahead and show the next one. So pets can be a big one. And it's one, at least from my experience, especially cats, that seems to be one of the modifiable, there's not many modifiable allergic risk factors that I can feel like I can do much about, but pets is definitely, one of them. So, if in this particular scenario, one of the things I would think about doing is doing an allergy test, either skin prick. I like to do the IgE RAST blood test because it's so simple, and I can get it the same day in clinic. Okay. I like to ask a lot about smoking at home. Go ahead and show the next picture. And this obviously this is something that I think it's always important to ask about. Most families, from my experience, are going to be honest with you, but they'll always say they smoke outside. I actually have one patient that actually said they do smoke inside, but they do this around the kids. So yeah, so so what's interesting though, yeah, I think that makes a difference when when you ask this question and you get a positive answer. I always, I try not to be. I feel like I'm always treading on thin ice when I do get a positive answer, because I don't want to come across as being judgmental or preachy, but I want them to also, reinforce that this is important. And there's pretty good data, at least that I've seen, that if a physician brings up smoking with a patient, there's a statistically higher likelihood that they're going to stop smoking. So I think it would be negligent not to at least, in a supportive way, talk about, the smoking issues. But I always feel like it's not enough for me just to say, you should stop smoking. I want to give them something that's sort of, more positive, that feels less judgmental. So you can advance the next slide, Brooke. And that's where we have these things like these Ohio tobacco programs, giving them an actual handout on, well, the first thing you do is, okay, do you have smoking? And they say yes or no. If they say yes, have you thought about smoking or stop smoking? And most of the times I'll get a yes on that. And then I say, okay, yeah, that's good. Here's what I know about the effect of smoking on children's health if they have asthma or wheezing. I'm glad that you're thinking about it. And let me, when you leave today, let me give you some things that can help you out, maybe if you need some help to move forward. So, Brooke, our group, we talked about maybe we might have potentially in the future a little bit more, another talk on some of the, what are the more concrete things you can do to help with smoking cessation in families. Okay. So before we do the next slide, any other risk factors that Angela or Ava that you guys think about? I guess we can certainly, Ava, you talked about immunizations, and anything else that you guys like to talk about?
I mean, Angela brought up the medication compliance issue, which I think is really, really important, because you could be spinning your wheels adding medications on, but if they're not taking the ones that you think they are, that is a huge, huge factor. So I like to sort of get a little more history about that, and then also, a little more family history about how prevalent asthma is in their family and how much education they already have about asthma, because I think sometimes if they have a lot of family members with asthma, they think they know everything and don't want to really hear a lot. So just sort of open the door for spacer use and things they may have heard different practices on. And then also, if they are a newer family with asthma, just making sure they have good education on really the high morbidity and mortality that can be associated with asthma as well.
Okay. Good.
Yeah, I would say spacer or not spacer use in this case. You can prescribe all the medications you want, but if you don't use it properly, it's like you've not been given it. So that's always high on my list.
Okay, good. All right. Anything else?
And then just clarifying how often they're using it, because it may be prescribed 2 puffs twice a day, but a lot of times family will say I used it for the first month and then I stopped because they were getting better, or they're using it once a day because they're worried about side effects, or
Yeah.
myriad of things.
Yeah, we have to remind ourselves that patients don't do anything as close as what we think is what we'd like them to do when it comes to treatment. I think the data I've seen shows that compliance is somewhere between 25 and 30%, maybe a little higher in some cases of what's prescribed and what's actually done. And the other thing, though, that's really frustrating is that we're actually very bad judges of whether or not patients are taking their medication. Now, you could look at their prescription, their refill summaries as one way to do that. But I've seen studies where they've given patients actual recording devices on their MDIs. And then they had the patient come back like a month later, and the physician would try to judge whether or not they think they're compliant or not compliant. And then they would match up the data from what the patients were actually doing, and the physicians might as well flip the coin. There were times when they thought, oh yeah, this patient's really compliant, and they weren't. Or they would say they're not compliant. They would think they weren't compliant, and they actually were. So it's a real challenge. But yeah, it's something I agree. It's something that we should always talk about with our families, especially if they're not doing well. All right. So how would you treat this patient differently? So next, we've done the risk, we've done the assessment of the severity control, and now we've talked about risk factors. We talked about spacers. We talked about talking about compliance. Anything else you want to do differently in this scenario? From a treatment standpoint. And Brooke, let's go ahead and advance the next slide. Yeah, so this is from Angela's talk. These are the NIH guidelines. So what would you change? Would you step them up? We're all saying they're not controlled, so I assume we would probably step up in this case. Is that true? Angela, I saw you're about to say something.
Yeah, I mean, I would, if you've confirmed and gone through all the other things and they, say they're taking it reasonably, a decent amount, and they've got a good spacer technique, I'd say they're still quite symptomatic, so I would step them up.
Okay. And then what would you guys thinking step up wise?
I think this patient is a great candidate for single maintenance and reliever therapy if it's explained to them properly.
All right.
So Angela, I would agree with you, but I think even if the patient was not compliant, I would probably do smart therapy for them too. At least that's how I often do it, because I think when they actually were getting medicine, they'd be getting their ICS and their long-acting beta agonist. So, if I found out the patient was like, we're using it a few times a week, but not using it as regularly, I think I would still do the same thing. So I don't know, Dr. Hardy or Dr. Marco, if you feel the same way or.
Well, once you advance the next slide, you'll get my thoughts on it. So I totally agree with you. And this is from Angela's slides earlier, which I think we got from Dayton Children's. And again, I think over the past year, we're evolving more and more toward this smart dosing or MARCH, therapy. And I totally agree. I think this is the future of asthma for the vast majority of our patients. It makes so much sense. The data is so strong that these medications are if not as good, maybe better than just an ICS alone. And the side effect profile is as good, if not better, as well. So,
Dr. Hardy, I'm just going to interrupt you for a minute, because I think that some of our people on the call today weren't on the call last week or 2 weeks ago, and I don't know if they had a chance to review the slides. If one of you just wants to go over just a brief summary of what smart therapy is, in case anybody needs a little refresher on that.
Sure, I'll be happy to do that. So it's basically based on, I think, a growing body of evidence that demonstrates that when patients are administered an inhaled steroid along with a bronchodilator, the outcomes tend to be better, as good, if not better, than if they're treated with just the way that we used to do stuff, like in this scenario, which would be an inhaled steroid with albuterol as needed, and then stepping up the inhaled steroid. So the combination of these two medications, makes it, simpler for the families. But most importantly, if you use the medications that have the formoterol, that's both the short-acting and the long-acting bronchodilator. So you may use the same medication for a flare-up as well as for maintenance. So the SMART meaning same medication and reliever
Yes.
therapy. Did I say
Single
that?
maintenance and reliever.
Single maintenance and reliever.
Yeah.
Yeah, that's right. And so there's the other advantages. I think it simplifies things for the family. And another huge advantage is, as I mentioned earlier, we know families don't always take all the medication we prescribe. Actually, my oldest daughter had asthma, and there were times when my wife thought I was giving the medicine, and there's times I thought my wife was giving the medicine. So, I'm a sinner as well. So, having, in those situations, if a patient isn't necessarily getting a controller medication, but they use these LABA, the inhaled steroid, the ICS LABA, when they're getting sick, at least they're getting some actual inhaled steroid at that time as well. And I'll talk a little bit more about the advantages of that with the next case. So anyway, the bottom line is there's just a lot of upside to being able to use one medication for both maintenance as well as reliever. And so I think I agree with Ava and Angela, but I think, I'm finding more and more cases to go ahead and prescribe these medications. I think it's going to completely take over my practice, at least for the patients that are 4, 5, and 6 and up moving forward. So these are the couple different medications that are out there that have the formoterol with the inhaled steroid. Always the big concern that many of us have is if a patient is using the SMART dosing, there may be, I'm always worried they're going to run out. So it depends if insurance is only going to cover one inhaler for both maintenance and reliever, there's the potential risk that they'll be using the medication, run out by the end of the month, and then get nothing. And we actually had an admission not too long ago with that when that exactly occurred. So I think this is still evolving a little bit from an insurance standpoint. Anyway, Angela or Ava, anything else you guys want to add?
Dr. Hardy, can we go to the chat about no role for albuterol in SMART therapy?
Let me see that.
Oh, I just answered. Huh.
Dr. Marco, thank you.
Sorry, I was trying to make sure.
Yeah. Yeah.
I don't know if you agree, but I still give albuterol just in case if they go over their allotted maximum number of puffs, more for red zone. I mean, I think I'm not sure in your guys' practice, Dr. Hardy specifically, how you do it. Ideally, it would be that single canister, so it would decrease confusion, but there is a maximum number of puffs, So
it depends on the kid. Yeah. If I have a patient that's pretty well controlled, I might just stick with one inhaler. Or if I think if it's a chaotic environment, I might. But I always have this I always have this insecurity that they're going to run out of the canister and that then they're going to have nothing. So, more times than not, Angela, I agree with you. I probably give them albuterol, but the problem is then I'm confusing the family. And that's the downside of that. So I know I've been reading some editorials that talk about trying to work with insurance companies to make the canisters hold more, or working with insurance companies to allow you to prescribe 2 of these a month. I don't know where we are with all that. And it's always a bit frustrating for me because I'm never quite sure what the insurance is going to cover and not cover for each individual patient, because it's there's so much diversity in what patients are being, what their prescribers allow them to do, or what their insurance companies will allow them to do.
And I tell families for the albuterol that this is like an emergency medicine. Keep it in the back of the cupboard, like put it in a special place where it's not just mixing with other inhalers, because I think you're right. I think otherwise we go back to the same issue of families just using whatever inhaler is in front of them and not really using it appropriately. So I sort of say, this is an emergency only inhaler. You really only busted out in emergencies, and that's when you're in your red zone on your asthma care plan.
Okay.
And
That's
I try to
good.
reinforce that repeatedly, but I know it's not easy, Justin. And I've always felt the same thing, like, it seems scary not giving them albuterol they have with them at school. Many times parents will say, what should I do at school? I say they should still have their Dulera or their Symbicort at school. So I always write for 2 inhalers, one for school, one for home, even if they're on the smart therapy. That's what I've been doing, at least.
Okay. What was there a chat? Let me see. Oh, got it. Okay, so yeah, we talked a little bit about spacer technique. You guys brought that up earlier. What do you all think of this spacer technique for this? He kind of looks a little older than an 8-year-old. Let's say he's, but anyway, what's your all thought about the spacer technique here? Any? I wish we could do a poll on this. Is this good spacer technique, intermittent spacer technique, or bad spacer technique?
So this is very well. It's not good. First of all, the 8-year-old, you can train them to use without mask, and even if they can use the mask, this mask seems too big for her.
Okay.
And then he's just sitting there relaxed. Because when I tell my patient to use a spacer, I want them to sit up and just inhale, just kind of like they inhale kind of forceful, not a little bit more than tidal volume, but for him, it seems that it's too relaxed. It's like when you give them nebulizer.
Yeah, I totally agree with you. Brooke, can you advance the next slide? This is kind of what you'd really like to see. First of all, a mouthpiece spacer, at least in theory, should be better than a mask. At least in theory, you'd be getting more of the medication into your lower airway, as opposed to a mask. A lot of it, some of it, I don't know what percentage, but a percentage is going to get caught up in the nasopharynx, or not not going to get deposited as well into the airways. And then, yeah, that patient's very passive. Their heads down. You need to be sitting up straight. And I have the luxury in my clinic, and I have a nurse who sees every patient with asthma and knows this stuff really well and spends time with them. Now that'd be hard to do in a busy primary care practice, but there are videos that you can give families, and there's education that we'll be providing, I believe, later on to help with this, if this is not something you have the luxury of time to do in your clinic. And we think that the spacer makes a big difference. I'd love to see the literature on that, but it's funny, I just saw a thing on Friday, and it was a little summary of a study that showed that patients with COPD that have bad spacer technique have significantly worse outcomes than people that have good spacer technique. So it probably makes a big difference. I assume it. We assume it does. Again, I don't know exactly what the literature is on that, but I think until someone tells me otherwise, I think good spacer technique is something we should review with families. Okay. And then we had the question earlier about providing a written step care plan. So that involves putting in what the patient's asthma medications are usually, and then having a good exacerbation plan. Next, we also review vaccines. Influenza vaccine we heard about from Ava, COVID, and even pneumococcal now is something that we would think about. So here's a question for Ava. Would you do Prevnar 20 in this patient?
Definitely. They're eligible because they're moderate to severe persistent asthma, so they should be getting Prevnar 20
Yep.
because given their age, they would have never had it before.
And so this is why this whole experience not only is great for me, because I was not aware of that. So so not only is it fun working with Angela and Ava and Brooke, but I'm also I'm learning stuff that I didn't know at all. Okay. And then think about a follow-up plan. Certainly if you're going to be stepping up, most what I read would suggest you need to reassess in a couple of weeks, 2 to 6 weeks. If you're able to check lung function, that can be useful. Sometimes it's not, but it's again, that's a luxury that if you can do it, it can have some benefit in your management. And then, as we talked about earlier, consider checking for allergies. Okay, let's move on. Next patient. So we have a 15-year-old with asthma. So he's had asthma in the past, occasional exacerbations in early fall while he was in grade school, but it's been a while since he's had a problem. Okay. He's currently taking Flovent 44 2 puffs twice a day, or allegedly he's taking Flovent 44 2 puffs twice a day. No history of any kind of chronic cough, no night symptoms, no exacerbations in the past year. You look at his EMR and there's really not much there except for, some bumps and bruises and things like that. But he continues to use albuterol 4 puffs before sports. And sometimes he will complain of some dyspnea with exercise, but only if he forgets to take his albuterol, not all the time, but he does still sometimes have some exercise-induced symptoms. Okay. Oh, and his favorite athlete is Jamar Chase. Brooke, you can show the next slide. This makes me sad after our horrible loss Sunday, but anyway, I was so confident I'd be able to have some happy Bengal pictures at the end of my talk today. But anyway, so he'll do the gritty for you in clinic. So, okay, so how would you classify the asthma? Would you say it's intermittent or persistent? And there's not you can make, I won't say any more. And what are your thoughts? All right, Angela, go ahead. I saw you.
You want my opinion? So
Yeah.
I think it's hard, right? So if he's taking the Flovent, is it well controlled on Flovent? Or if they're not taking it, is it well controlled? Or is it just intermittent off Flovent? So it's hard to know, I guess.
And is he really even taking the Flovent? That's exactly right. So again, I'm throwing these up there because these are the kind of scenario, this is something that we deal with all the time. You can make a case that this is persistent because he's on a controller. And I probably would. I would probably call it persistent because he's on a controller. But if he was not on a controller, or if he's not taking his controller, then it's probably intermittent. Now, how about, would you say well-controlled, partially controlled? Can you go back, Brooke? Well-controlled, partially controlled, or uncontrolled? Any thoughts?
I think it's well controlled.
Yeah, I'd say he's well controlled. If you go back to that GINA, you don't have to change the slides, Brooke, but if you went back to that GINA classification, occasionally has exercise symptoms, but it's pretty unusual from what we're hearing. So I'd say he's well controlled. And then, but if you were to say he was not well controlled, you would probably call him mild, but again, don't tell him that. So I would leave it as persistent, well controlled, and probably just at least I would probably chart it as mild, but I wouldn't necessarily tell the family that. Okay. So would you treat this patient differently with this story? And remember, they're on Flovent 44, 2 puffs twice a day, and albuterol before exercise and as needed.
I don't know if you want my opinion again.
Sure.
Sure. So I guess there's a few factors. Sometimes I always depend what season it is. So are they very well controlled and it's fall and that's when they have their seasonal exacerbations? I might say, oh, let's hold off since this is your symptomatic time of year.
Right.
Or even if it's not, and we talked to them about using the ICS LABA, like Symbicort or Dulera as needed as like a trial of almost like a step down therapy would be an option too. I think you could do it anyway, really.
Okay, good. And I like how we're again that we're talking about how there's lots, there's not necessarily one right or wrong way here. There's different options. Okay, Brooke, let's go ahead and advance. So if we go to the NIH NHLBI steps here, he would be somebody that's would be on probably step 2 because he's on a daily low dose ICS. And so, yeah, I think it would be not unreasonable to consider stepping him down off of his daily steroid, but you'd want to watch him closely if you do that. And breaking a good advance. This is where it's important to kind of think about the concept about using, if you are going to do, if you're going to take him off daily controller medication, that if he is on, when he does have an exacerbation, to think about using the ICS-LABA combination. So at least what I found, so again, going back to the GINA, there's 3 big reasons why the GINA doesn't include SABA alone in their step 1. They always want you to use an inhaled steroid. And the reason being is that your airway inflammation is found even in those who have intermittent symptoms. Next. Regular use of short-acting bronchodilatic albuterol will increase the allergic response and airway inflammation and reduces bronchodilatic responses to SABA. So you do get some desensitization to the effects of the SABA. In fact, you might even get hyper-responsiveness. And finally, the regular use of the SABA is definitely shown to increase the risk of exacerbations, low lung function, and asthma-related deaths. So the point is, probably want to use an ICS-LABA almost either as fluticasone with albuterol or your combination ICS-LABAs together, even if you're going to step down and use intermittent therapy. So, Brooke, yeah, so, in this patient, you could make an argument that you can move them to something like Symbicort 80 2 puffs before exercise and PRN, or the Dolera 100 2 puffs. So should we take a pause here about questions? I think I saw the chat was going, but I'm not able to look at the chat and unfortunately talk at the same time.
Oh, no, that's okay. Dr. Johnson, since you answered it, can you review Dr. Kumar's question so we can kind of get it on video here, please?
Sure. So Dr. Kumar asked if nirsevimab or before the new RSV medication would be indicated for a child 8 to 18 months or 19 months if they had asthma. And, looking at the indications for nirsevimab, it's really for patients with more severe illnesses. So they said congenital pulmonary abnormalities, chronic lung disease of prematurity, or severe CF. Now, if you had somebody with chronic lung disease, like if you had a patient born at 28 weeks who then became a chronic wheezer, I think that would be an indication. But if you had a patient who was born at 38 weeks who then had recurrent wheeze, you could certainly try to get clearance for that, but I'm not sure that they're going to meet the muster for the indications for that new medication. Now, we know this year we probably won't have any at all, or we have very few doses, so it really should be reserved for the sickest of the sick. But next year, this may be a more emerging discussion. But for right now, I don't think the indications would that child will meet the indications.
Thank you.
And hopefully we'll have an RSV vaccine for kids in the near future. And then that's gonna make our lives much easier, I think. When we get a rhinovirus vaccine, that's gonna be really something. But okay, well, that's a good segue into this last case. So
it is. Dr. Hardy, just real quick, we want to be mindful of time. I think we can get through your last case, especially because there was a question on it, and all the other information that we didn't get to, I will be sending that out. So no worries there. Thank you.
Okay. So go ahead, advance, Brooke. So full term, had RSV bronchiolitis back in the winter when they were 4 months old. Since the fall, has these episodes just like we talked about, where it'll be fine for a while, then looks like it gets a cold, they'll be coughing, they'll wheeze, they'll go on for a long time, and then they eventually get better. Got some albuterol, which seemed to improve them sometimes, and had prednisone already once this year, maybe made things a little bit better. Okay. But really, the asthma predictive index is quite low. No family history. There's no smoking. There's not lots of pets in the house. There are really no risk factors for asthma that you're identified by this history. And oh, by the way, I just started full-time daycare in the summer. So, all right. So based on that story, I'm going to go to my experts here. Is this intermittent or persistent, well-controlled, partially controlled, uncontrolled? And if it's not well controlled, how would you classify this scenario, which is, which perfect question to ask. It's something honestly, I struggle with, my classification. It's probably going to depend on, patient to patient, but any other thoughts you guys have?
I think some people won't even call this, I mean, they might call it asthma. You're going to have different people say recurrent viral wheeze versus asthma even. I'm curious what Angela would say about that. If it's only with colds, what do you think, Angela?
I often say viral induced wheezing episodes, and then from there I characterize that they are controlled or well controlled, or like controlled in the sense that they don't have to go to the emergency room or get oral corticosteroids or the hospital, or not well controlled. And then I usually like make it very clear there's no baseline symptoms in between.
It's almost, yeah, it's almost like it doesn't really apply quite as well, does it? This whole classification scheme, which I think is what is it Fariba? Is that, did I say that correct? What was bring, that kind of your question?
Yes. Yes.
Yeah. Okay. So let's move on since we're getting a little short on time. How would you treat this patient differently? All right, they're getting albuterol right now, PRN. What would you do? Any thoughts? Or
so I sorry, I can't remember if they just had the one episode or two, but
we'll say they've had 2 or 3 episodes. The prednisone once, and
so I often try to reference the kind of, it was taken from the MIST trial, but the viral wheezing, kind of intermittent inhaled corticosteroids in the 0 to 4-year-old is kind of like the thought process here is that since they have no symptoms in between, do you really need to do a everyday daily medication if it's very intermittent and they the severity of them perhaps is maybe not so extreme? I would do kind of like an intermittent regimen based off of the guidelines, but then you have to be very thoughtful and careful, at least I am. If they've had more than 2 severe exacerbations, meaning like they've had emergency visits or hospitalizations, I then start to say, is that intermittent regimen going to work for you or not?
Perfect. That's Ava, you agree?
Definitely.
Yeah, I mean, it's reassuring when I do this to hear you guys, because this is very similar to what we do. Brooke, do you mind just advancing? So this is, again, going back to NHLBI guidelines. And this would be, you're in the dilemma. Is it like a step 2, step 3, step 1? I didn't give you guys enough history for you to really, say for sure which of these scenarios it is. But it brings up the intermittent asthma issue for these young patients, where you think about adding a short course of daily inhaled steroids along with your SABA. And I think that's definitely, at the least, that's what you'd want to do here. And I always have to be upfront with the families. There are going to be some viruses. It doesn't matter what you do. They're going to cough and wheeze, right? But what you're trying to do is reduce the risk of an exacerbation. So that has to be kind of clear, I think, to families that, you may not necessarily be able to have a huge impact on symptom control, but you are going to reduce the risk for exacerbation. So it kind of gets to that symptom control risk modification issue, that we're talking about. So one more
and
slide.
I just want to
go ahead.
reiterate that it would be high dose for the short 7 to 10 days, not the regular dosing. So high dose, which you may have to tell families who are used to asthma this, and they're doing this for a 2-year-old, why you're doing that high dose. So.
Okay. So we have this discussion here in Cincinnati, preschool wheeze management, because it is a different animal and it's hard. So we're more likely to begin to go from, we just talked about the intermittent steroids. So a patient comes in, what you do is you tell the family the first sign of a cold, you start them on, Flovent, 44, 4 puffs twice a day, or 110, 2 puffs twice a day. There's a couple of ways you can do that. But we're more likely to begin a daily inhaled steroid, like Angela talked about, for the following scenarios. If they're allergen positive, if they have persistent symptoms, like you talked about, or they've had severe wheezing. So in those scenarios, we're more likely to go say, hey, you're just going to probably just get on your fluticasone 44, 2 puffs twice a day at least throughout the fall and winter, and maybe we'll reevaluate in the spring. But then there's an alternative treatment, and this would be a whole nother conversation and talk. But another thing that seems to be fairly effective in these preschool wheezers, especially if they're not responding as well to inhaled steroids, is the anti-inflammatory benefits of azithromycin. So I've had some success with that, and there's definitely data out there. There's 2 studies. You're seeing different doses because these are 2 big studies that were done in preschoolers that have been shown to be effective in reducing exacerbations. That's probably not something we're going to have time to talk about today, but it's certainly on there. So, finish up, kind of I think of it as sort of like 5 steps. Number 1, you're going to classify your asthma, intermittent, persistent. You're going to talk, are they controlled or not, or partially controlled, and what's the severity? You're going to identify risk factors and comorbidities, including vaccines. You're going to step up, step down, or stay the same. You want to review inhaler techniques and make sure you have a step care plan and a follow-up plan as well. Okay.
Thank you. Good timing. If anyone has a question, we have about a minute. But I want to also thank everybody for joining today. I will be following up with an email, and this recording will be posted on the website. But any questions for the team?
I just want to first thank Angela and Ava. This was kind of cruel for me to not give you guys these cases ahead of time, but I really wanted to. I think it was good for the other physicians here to see that these are, the general concepts are the same, but getting into the nitty-gritty specifics can be a little bit variable. So thank you all for being patient and kind of being put on the spot by me.
No, it was fun. I enjoyed it.
It's good. Okay. Hearing none, if you think of anything, please email me, but I will be in touch. Thank you, everybody. Have a good day.
Bye.
Thank you. Bye.